So it gives me great pleasure to welcome everybody to today's overview of soft tissue sarcomas. My name is Shani Zaidi. I'm a clinical oncologist based at the Royal Marsden Sarcoma Unit in London, in the UK, and I'm going to be your chair for the next hour or so. I'm just letting people get admitted, but in the meantime, I'm also going to do some introductions. Firstly, I'd like to thank the SIVU admin and AV team for the invite and for setting up this fantastic virtual platform, which I must confess has absolutely exponentially increased the kind of availability of knowledge for everybody, internationally, and I'm really impressed. I'm just, echoing everybody's thanks. I know we don't say it often enough, so I'm really grateful. I'm also grateful for the invite today to chair two fantastic speakers who are both up-and-coming experts in their field, and I've had the pleasure to work with both of them actually. These two speakers, Raza Sayed, who's going to give you a little wave now, brilliant, and Yolanda Augustin, who's also going to give you a wave, thank you. They've actually harmonized their talk into one overview presentation to highlight the challenges of managing rare cancers. And although the title of this talk is about soft tissue sarcomas, it's really about lessons we have all learnt from managing these complex tumors, allowing us to develop collaboration, identify problems, solutions, not always with the full set of resources that we have in other common tumors and also non-cancer conditions, and more importantly, think about future opportunities, and most importantly, what I suppose other AHPs and medics can learn from this model, both within and outside cancer medicine. So just moving on, Raza, if I just give you a little introduction, once again, you're a fantastic surgical oncologist based in Karachi, where you trained at AKU, Al Khan University, and you've traveled extensively around internationally, focusing not just on abdominal and peritoneal malignancies, but also now in soft tissue sarcomas. And you've actually moved across several very high volume soft tissue sarcoma units. And that's the key importance here. The message is about, moving around, training and getting exposure to high volume centers. You've most recently finished a 2-year attachment in our surgical sarcoma unit. And I'm very, very grateful for the support that you've given us, both on the service side and also on the research side. And so we're very, very sad to see you leave a few weeks ago. And I think you're just managing to relocate now and settle back in Karachi. So you're going to be doing some fantastic work there, setting up things. Moving on to Yolanda. Yolanda Augustin is a post-CCT oncologist who's originally from Malaysia. Yolanda's got a very unique set of skills, really on both global oncology and also in soft tissue sarcomas. So Yolanda, I know you trained in the UK. You completed your specialist training at the Royal Marsden. Actually, we were registrars together not so long ago, is what you're going to say. And you completed a fellowship actually within our unit, focusing both on advanced radiotherapy techniques and also systemic therapies and designing clinical trials. You've also been doing a PhD on designing novel anti-cancer therapies. And your passion really is about leading a global oncology program, which you'll be doing at St. George's Hospital, and trying to develop affordable therapies and diagnostic cancer medicine. It's been an absolute pleasure working with you. And I know you were juggling several projects at the time for us as well. So it's been a pleasure working with both of you. So I'm going to hand over to you now, both. I think Raz, you're going to start off the talk, and then Yolanda, you're going to come in halfway, and then we'll have time hopefully for some questions and some discussions really. So over to you, please. And thank you once again to everybody for attending today for this fantastic session. I'm really, really excited about this.
Bismillahirrahmanirrahim. Thank you very much for this opportunity to speak at this seminar, and I thank you for this wonderful introduction. It was a pleasure working with the whole unit and with Shane and Yolanda, and we developed, Shane and myself developed a lot of personal affiliation, so I'm really grateful for this introduction. Thank you very much. So we will start our talk basically how a rare disease challenges us and how we can seek opportunities within these challenges. So we basically look at these challenges in diagnosis and management of soft tissue sarcomas, try and understand the multidisciplinary team approach in the complex management of soft tissue sarcomas, and the indications of surgery, radiotherapy, and systemic therapy in the management of these sarcomas, and the importance of quality assurance in both radiotherapy and surgery. And also look at the opportunities for networking and capacity strengthening through regional and global collaboration. Both of us don't have any disclosures. So in summary, sarcomas are tumors arising from the connective tissues that originate from the embryonal mesenchymal tissue. And they could arise in any tissue with, which contains supportive connective tissues. We can see them arising from anywhere in the body, and the different types of tumors arising from different cell type gives us the diagnosis subtype. However, over the last decade or so, we have had tremendous understanding in the molecular biology as well as genetic changes within the sarcoma that could potentially either lead to cell proliferation or actually determining the behavior of these sarcomas. So it's much more than the histological subtype and the location now. When we talk about rare diseases, they're defined differently in different areas, but the most common definition used in Europe is 1 in 2,000 people, which just means 5 people in 10,000. Less than that incidence is considered a rare disease. And there are a large number of rare diseases within the world, more than 6,000 known. The problem of having seen these diseases infrequently and having so many people encountering these diseases results in a delay in diagnosis and recognition, and thereby a lack of an effective treatment because we have so few people or patients with these diseases to work with. Sarcomas themselves are rare diseases with about 5,000 people a year developing sarcomas. Within Europe, it's 5.6 per 100,000 people. And they're about less than 2% of all cancers within the UK. I'd like to highlight the concept of heterogeneity of sarcomas by asking you to imagine a ball used in any kind of sports. And mostly when we do this exercise, we think of 1 or 2 sports that we commonly play or see being played. But when we look at all different types of the sports, there are more than 100 types of ball sports as per Wikipedia. And all these balls that we can see in this picture are actually used in one or another form of sports. Each of them played on a different field or with different set of rules. So that's like an example of a real heterogeneity, and sarcomas are no different. There are more than 100 morphological subtypes that could occur at any location within the body, and a different cell of origin will lead to a distinct histology. They could arise in the soft tissues or the bones or within the visceral organs like GIST and uterine sarcomas. And more recently, as our understanding of their molecular or genetic basis has improved, we tend to see different kinds of sarcoma with genetic fusion abnormalities. And this concept of a black and white division between benign and malignant doesn't hold true for sarcomas. It's actually a spectrum. All these more than 100 subtypes of sarcoma lie somewhere along the spectrum, ranging from a benign disease to a locally aggressive to a malignant sarcoma with the potential for metastatic disease. So one key concept is sarcomas are rare and heterogeneous. When we see something rare, the problem occurs is that they could emulate or mimic something that we commonly see. An example is this lump in a 50-year-old gentleman who had this lump for more than 6 months and presented to his GP. And a local surgeon thought this to be a benign lipoma and excised this, and histopathology was not sent. a few months later, this recurred in the same place with this horrible appearance. And this clearly is a disaster in the management. And this is a problem with sarcomas. Sarcoma is a typical example of oculobrachial reflex described by Professor Thomas from Royal Marsden, that when a surgeon sees a lump in the soft tissue, he doesn't process this information to the cortex, but directly wants to take it out before determining its true nature. And this results in a problem. When we look at sarcomas that are excised somewhere else, inadequately requiring further excisions, even further excisions do not result in an equivalent oncological outcome or survival compared to if it was resected with a full plan. So an inadvertent excision or an unplanned excision, which we commonly call a whoops excision, because the surgeon as well as the patient are both surprised to find this as a sarcoma. So on average, looking at multiple reports, about a third of sarcomas have inadvertent excisions. Historical data suggests that if you don't do anything, almost 70% of them will recur. And the management requires a wide re-excision, which definitely be much wider than if this tumor was excised as a planned operation. They may require additional reconstruction, which would otherwise not have required, or radiation therapy, which would otherwise not have been required. And almost half of these situations, a residual tumor is found within the excised tissue, which is a very adverse prognostic feature. So the second lesson is an unplanned inadvertent excision for soft tissue sarcomas has got a worse outcome as compared to surgery, which is planned and a diagnosis established. How do we diagnose and work these lesions up? So an excellent screening method is an ultrasound, which very cheaply differentiates between a lump within the soft tissue that could be cystic, which could be fatty, and it can also differentiate benign and malignant tumors, also tell us about the depth of this lesion, any vascularity, or about the actual size of this lesion. Although MRI stays the gold standard, it's definitely a resource in many countries that is limited. Cross-sectional imaging, MR and CT play a main important role in local staging of this disease. We need to understand which anatomical barriers confine a lesion and how to plan its removal. We can determine the size more accurately, tell about its extension beyond the anatomical compartments and plan surgery accordingly, or relationship to any adjacent structures, which would be very critical and should not be taken out. FNAC essentially has no role in the diagnosis of soft tissue sarcomas. The gold standard is a core needle biopsy that takes out cores of tissue, which is analyzed by a sarcoma expert pathologist. There is the risk of reseeding if this biopsy is planned in the direction of the future incision and the tract is excised is virtually zero. And it's important to perform a core needle biopsy because a lump in the soft tissue that could look like a sarcoma could turn out to be a sarcoma or a benign disease or a locally aggressive disease or a cancer that would otherwise not require excision. So it's important to establish the diagnosis beforehand. And a core needle biopsy can very accurately differentiate between a benign and malignant lesion. So the next concept is that imaging and core biopsy are the cornerstones of diagnosis. We not only need an expert pathologist, but also an expert radiologist looking at the imaging of soft tissue or wherever the location is. The question is if all soft tissue sarcomas should be treated as a specialist center. And we do see from evidence that the outcomes for sarcomas that are treated at an expert center both in terms of local recurrence as well as overall survival, are much, much better significantly compared to if they were not managed at a sarcoma center. This leads to the problem that result in significant delay, on average about 3 months between the first consultation for the problem to the time that this patient is seen at an expert center, which is a significant problem and results in poorer outcome. So the UK guidelines issued in 2000 and then endorsed by NICE in 2006 suggest that all soft tissue lesions which are deep, which are increasing in size and are more than 5 centimeters and have pain should be considered soft tissue sarcomas until they're proven otherwise. The GPs have access to urgent ultrasound that should be done within 2 weeks. And then they also have a referral pathway for sarcoma units that takes place within 2 weeks. And this is based on all the guidelines that there should be a prompt referral to an expert center, and a specialist multidisciplinary team specializing in sarcoma should determine the appropriate treatment. And this treatment should be carried out by specialists with expertise in sarcoma, and support and rehabilitation for these people, as well as the fact that these units should collect their data and take part in audits and training. When these guidelines came out, and it's a very interesting study that's recently been published and looked at the outcomes of sarcoma 10 years before these guidelines were published and the subsequent 10 years. And it found that of a more or less significant patient population, the median size of the tumor was significantly decreased. The percentage of inadvertent excisions was significantly decreased, as well as the 5-year survival was also significantly increased if these guidelines were followed. The French experience, the network of sarcoma specialist centers also looked at the outcomes of patients who were managed at expert sarcoma centers compared to patients who were not managed at an expert sarcoma center, and there was a significant difference in survival. So early referral to sarcoma specialist center improves outcomes. Retroperitoneal sarcomas are a special challenging situation because of its anatomic location, and they should always be referred to a specialist center. The diagnosis is established by a core needle biopsy, and the surgery must be performed at expert center. And this actually is a case to highlight the need for specialist opinion. This retroperitoneal obvious looking mass, if seen at a non-expert center or someone who's got no experience in management of sarcoma, would most likely be taken out following these red lines. However, the true extent of this soft tissue sarcoma, which is actually arising from the fat and is the most common type of retroperitoneal sarcoma, is called the liposarcoma, which has a well-differentiated component that looks like normal fat tissue, as well as a de-differentiated fatty component that looks like this. So the actual extent of the tumor is this. But even if this is taken out as the fatty component of the tumor, it results in a high risk of local recurrence. And therefore, the current standard approach for these kind of tumors is taking out all the adjacent organs that can be taken out with a negative margin over the critical structures that could not be removed. Collaboration is a very important aspect of rare cancers that has helped us in understanding the disease biology as well as treatment modalities. And the Transatlantic Retroperitoneal Sarcoma Working Group, as it was formed initially, and later on, everyone from around the globe took part in it, and it was then changed to a Transatlantic Australasian Retroperitoneal Sarcoma Working Group that meets twice a year, either online during a pandemic or in a hybrid fashion. And this year it will be a totally interactive face-to-face meeting. I'm proud to say that Pakistan has also been a part of this working group for quite a few years. They collaborated all these expert sarcoma centers and the data from these patients came up with their initial presentations of more than 1,000 retroperitoneal soft tissue sarcoma that helped us understand that different histological subtypes have a different pattern of local recurrence as well as a systemic recurrence, and therefore the treatment needs to be tailored to the pattern of recurrence for each histological subtypes. And our understanding continues as this data is collected on a prospective database by the TOPS-WIG, which is centralized, and publications regarding each histological subtypes or location keep on coming. So this is a very dynamic group which has collaborated and has actually produced a randomized trial regarding management of retroperitoneal sarcoma, comes up with guidelines, and has more trials underway. And this is a key example of how, in a rare disease, experts from all around the world can get together. So this rare cancer model actually can be a key to even common cancers, because as our understanding of the molecular basis of these common cancers, as we call them, increases, we realize that within these common cancers, there are so many multiple subtypes with a heterogeneity because of their molecular basis. And this is the key for precision medicine. We require expertise in diagnosis of each of them, and a different biological behavior for each molecular subtype leads us to define or tailor the treatment strategy. A network of collaboration which looks at the real world data from expert center and subsequent networking and collaboration with the translation research is how we improve outcome in these cancers as our understanding evolves. And it also needs involvement of all stakeholders, which are clinicians as well as the patient and patient advocacy groups, the researchers as well as the funders, who all get together and combine their efforts in terms of resources, in terms of getting data, and in terms of expertise, which could, parts of which could be in one center or the other. So the final message from me is collaboration is key in understanding and managing these challenges. I'll hand over to Yolanda, who will take over from me now. Thank you.
Yeah, thank you so much, Raza, for a great setting of the scene and introduction to our talk today. And thank you so much as well to the SIVU team for inviting us to speak today. It's a great pleasure and honor to do so. And I also have been very impressed with the educational output and all the different lectures that you have on a weekly basis. So yeah, very, very grateful and honored to be here. Raza, okay to switch the slides instead of me going in? Yeah, thank you. Next slide, please. Yeah, sorry, the previous. So we're going to think about the role of radiotherapy in the multimodality management of soft tissue sarcomas. And I think it's been said before, but it's always worth thinking again. About how tumor biology actually in soft tissue sarcomas is king, patient selection is the queen, and the technical maneuvers such as radiotherapy, surgery, and chemotherapy are the prince and princesses. So radiotherapy in soft tissue sarcoma actually presents a particular challenge, just because STS can actually present at any anatomical subsite. So that goes from head and neck to thoracic, to skin, to cardiac sarcomas, which are very rare, but we have a substantial experience at our center at RMH as well of treating these super rare tumors, to the more common extremity or limb soft tissue sarcomas. In general, the TNM staging is actually as per the local tumor site, and also the radiotherapy, principles of radiotherapy application are based on the protocols for the local tumor site. So just thinking about what the role of radiotherapy is in the management of STS. So first of all, it's very important for us to identify our treatment intent. So are we approaching this patient with a radical treatment paradigm, or is this palliative treatment? Then we think about the role of radiotherapy in the neoadjuvant or adjuvant setting. neoadjuvant being preoperatively or adjuvant being postoperatively. And in this setting, our aim really is to try and improve local control with the radiotherapy. Overall, radiotherapy reduces the risk of local recurrence by about 10 to 15%, but it also allows preservation of function with similar control rates and survival to radical resection. So in the past, where perhaps more patients may have undergone amputation for limb sarcoma, with the use of radiotherapy as a part of multimodality treatment, we're actually able to help save those limbs and spare function and quality of life in these patients. We do sometimes also consider primary radiotherapy for an operable disease in order to gain better local control and also patient quality of life. Frequently, we're also giving radiotherapy as part of a palliative treatment paradigm in terms of managing patients with metastatic disease. And in very selected cases, we may also think about the role of stereotactic body radiotherapy or proton therapy as per guidelines for other tumor sites. So the main guidelines that help to guide our practice are the ASTRO guidelines on radiation therapy for the treatment of STS in adults, and also the ESMO guidelines, which are very practical guidelines for soft tissue and visceral sarcoma management. And we also have some national guidelines in the UK that are published by the British Sarcoma Group. So having a think about what are the indications for radiotherapy in extremity soft tissue sarcomas. So typically we're selecting tumors that are large, high grade and deep seated. The margin status is commonly R0 or R1. And we also consider radiotherapy in patients who've had multiple surgical interventions where further surgery is not feasible. And sometimes in patients with low-grade tumors, where if they were to actually develop a recurrence, it would lead to very mutilating surgery, or surgery again is just not possible. So the main clinical trials that influence or have guided our radiotherapy planning are the Vortex, IMRIS, and Do-Re-Mi studies. I won't go into these in detail today, but I've just provided some links in the talk, and of course, very happy to discuss offline as well after this lecture. So historically, surgery and radiotherapy together offer high local control rates, but they don't impact on overall survival because of the risk of metastases and distant relapse, if you like. As I've mentioned, radiotherapy pre or post-operatively improves local control rates by about 10 to 15%. And overall, the 2-year local relapse-free survival from the data that's been published extensively is about 90%. However, we do know that with preoperative radiotherapy, we do have increased wound complications, whereas with postoperative radiotherapy, we have more late complications. So the Memorial Sloan Kettering group have published a nice nomogram called the Sarculator that basically also is a tool that helps us to predict survival benefit in patients with different types of STS. But I think the main underlying message, even in using the Sarculator, is that tumor biology really is an important predictor of survival. And I think we've seen that as well from the ball, the different ball situation or slide that was shown by Raza, how essentially we may talk about these as soft tissue sarcomas, but they really are a very heterogeneous population of patients. So just thinking about the benefits or the setbacks of preoperative versus postoperative radiotherapy. So in the preoperative setting, typically we will have smaller volumes in terms of radiotherapy outlining and planning. In the postoperative setting, we often have larger volumes. Looking at the dose that we deliver in the preoperative setting is lower at 50 gray, whereas in the postoperative setting, we're typically treating patients to 60 to 66 gray. In the longer term, we tend to see less long-term effects of radiotherapy in patients who undergo preoperative radiotherapy, but that is balanced by a higher incidence of wound healing complications. However, I would say with good communication and collaboration between the surgical team and the clinical oncologist delivering radiotherapy, and of course, the wider multidisciplinary team, we can actually usually manage any wound healing complications quite effectively without too much of an impact on patient quality of life. Of course, when we're giving preoperative radiotherapy, we would also want to consider the risk of tumor growth during radiotherapy. That is always a risk, but I think that's also where radiotherapy quality assurance and weekly imaging of the patient and also weekly review of the patient in clinic to basically monitor for rapid growth and to ensure that there's still adequate coverage of the tumor becomes very important. And in the preoperative setting, another potential advantage, although of course it's quite unusual or rare, is being able to take a patient from an inoperable situation to an operable situation by downsizing the tumor. I would say in general, in the UK and Europe and America, probably over the last 5 to 8 years, we have seen actually a shift away from a tendency to do more post-operative radiotherapy to more preoperative radiotherapy where possible. And it actually comes down to the fact that we're able to deliver a lower total dose that actually then translates to less late toxicity or longer term side effects. And also because we're dealing with a smaller area that we're treating in the preoperative setting. So some important late complications to consider in sarcoma radiotherapy would be for limb sarcomas, obviously fibrosis and induration, lymphedema, a risk of bone fracture. And then always to think about, depending obviously on the site or the dose that might be received by the gonads, it would be also infertility a consideration. And this is also quite important to think about because a lot of patients with sarcoma will also present at a younger age. So just thinking about the indications for retroperitoneal sarcomas. So these represent 10 to 15% of all soft tissue sarcomas. And unfortunately, the local recurrence rates in this population remain high at about 40 to 80%. The extent of resection along with the tumor grade are the most important factors affecting survival. However, following publication of the Strauss trial, we consider radiotherapy only in individualized cases at high risk of R1 or R2 resection. And it is very important to define the high risk margin prospectively together with the radiologist and the surgeon. Indications for uterine soft tissue sarcomas. So again, adjuvant radiotherapy hasn't been shown to improve local survival or control from the EORTC GOG trial. And so we recommend it in very selected cases where there's a concern for local recurrence, for example, with parametrial extension or pelvic side wall extension. Indications for head and neck radiotherapy for soft tissue sarcomas. So typically the standard of care is for us to treat the patients with surgery followed by post-operative radiotherapy. And the reason for this is because in the post-operative setting, why we prefer post-operative radiotherapy is because of the risks to organs at risk with rapidly growing tumors. Unless we've got an obviously radiosensitive tumor such as SFT or solitary fibrous tumor or myxoid liposarcoma. In terms of pediatric soft tissue sarcomas, we would treat patients with Ewing sarcoma according to the EE12 protocol and rhabdosarcoma according to the FARMS RMS protocol. And these are studies that are currently in the UK. And typically we're looking at combination chemotherapy followed by local therapy, and preoperative radiotherapy is preferred. So in terms of radiotherapy quality assurance, immobilization and setup is very important. And this just shows some of our patients with sarcoma who are going through the radiotherapy planning process and having their molds made for immobilization. Also, we've got to think about what to irradiate. So this is a patient with a post-op, coming for post-op radiotherapy after having a limb sarcoma removed. And this is where I think it just illustrates how important it is to discuss these cases with our surgical colleagues, to really be able to identify with a combination of radiology, surgical notes, and multidisciplinary input where the tumor bed lies, where the donor site is. And again, it's very helpful, I think, to have these discussions preoperatively as well, not just after the event of surgery. Also, we think about dose. So there's a lot of debate now in the sarcoma world about whether or not we can de-escalate dose in certain tumor types that are particularly radiosensitive, such as myxoid liposarcoma, or should we be dose escalating in certain tumors that are more radioresistant, such as pleomorphic liposarcoma. Again, this is an area of interesting research, and if there are any studies where these different dose fractionations are being offered, then we should consider trying to enroll our patients in these trials. This just illustrates different planning techniques and how with conformal radiotherapy versus intensity modulated radiotherapy, we are getting more conformal dose to the tumor with the intensity modulated radiotherapy on the right, but we are actually getting more of a low dose wash to organs at risk with that technique compared to the conformal radiotherapy on the left. In terms of quality assurance for radiotherapy planning, we've also recently had the Royal College of Radiologists in the UK publish radiotherapy target volume definition and peer review guidelines. And I think this has actually been really helpful in terms of streamlining and also improving the service in the UK. So this also comes down to having a regular weekly audit meeting, which is actually multidisciplinary in nature, involving both the oncologists, radiation oncologists, as well as the treatment radiographers, and also the planning physicists, and the clinical nurse specialists that are also going to be managing the patient and assessing for toxicity, and ensuring that apart from reviewing the verification imaging and making sure that tumors are still being covered adequately, we also look at peer review of volumes, because these are actually very challenging tumor types where obviously only treating a few of each type per year perhaps. And I think this is where actually peer-to-peer review of volumes becomes even more important. And also in sarcoma, it is more difficult to follow a very strict protocol sometimes when it comes to radiotherapy planning. There can sometimes be variability in terms of our target volume definition. So having additional peer review of this really helps to ensure that the tumor is being targeted effectively and we're minimizing dose to organs at risk. So just very briefly in terms of the role of chemotherapy with radiotherapy. So historically, interdigitated radiotherapy and chemotherapy. However, that's possibly too toxic. So at present, we tend to only think about sequential or concomitant chemotherapy in very selected cases. It's not being used as a radiosensitizer per se, but basically looking at it in borderline operable chemosensitive and radiosensitive tumors, such as synovial sarcomas. And is there a role for stereotactic ablative body radiotherapy in the management of sarcoma? Well, we do think about it sometimes in selected cases with oligometastatic disease. This just illustrates a patient who basically had sarcoma recurrence and metastases to the paraspinal area, and there was a risk of spinal cord compression. However, it was not suitable to basically refer this patient for surgery or radiofrequency ablation, and hence the patient was actually treated to 27 Gray in 3 fractions and had a good clinical outcome. So in summary, soft tissue sarcomas are rare. They're very heterogeneous tumors. They require robust diagnostic and referral pathways, and management at specialist centers really does improve outcomes in these patients. Multidisciplinary team decision-making is very important. And, I think in this, it's not just the surgeons and the oncologists, but also our radiology colleagues, our histopathology colleagues, because, we need to get the diagnosis accurately done. We need to make sure that in terms of radiology, we're getting adequate staging upfront. And then, of course, our clinical nurse specialist team, our physicists, our treatment radiographers, they all become a very important part of the MDT in order to try and ensure that we deliver the best possible radiotherapy to patients and also get the best clinical outcomes. And again, we cannot stress this enough, but prospective evaluation of grafts and reconstruction techniques is always very important. When I was training with Dr. Zaidi, he basically encouraged me to actually go to surgery to actually see how the surgeons conduct, their very in-depth and sophisticated treatments. And I think that was hugely useful because sometimes it's very easy to actually become dissociated from the process, to become very focused on your own particular area. Whereas when you actually understand what your colleagues are doing and you have a broader view, that really does actually help when it even comes to radiotherapy planning, for example, because then things like the resection margin, the areas at risk, they just become a lot clearer, and the whole process makes a lot more sense. It's very important to try to audit our outcomes and also to look at the quality assurance and control side of things in our centers, and also to constantly think about opportunities for research and collaboration in this challenging tumor type. And in certain clinical scenarios, we also need to think outside the box and individualize patient care. So these are just references to potentials for national and international collaboration within the sarcoma world. And we just also wanted to say thank you to all the contributors and contributions from our colleagues that also went into the preparation of this presentation, from our colleagues at the Royal Marsden Sarcoma Unit, and also from, I think, Raza's fellowship, the support that was received from various other international organizations as well. And these are our emails. If you have any questions after this talk, if you would like to contact us, we're always very happy to be in contact and to receive your queries and to try to have a discussion and to support wherever we can. Thank you very much.
Thank you, Raza and Yolanda, for fantastic kind of whistle-stop tour of soft tissue sarcomas, everything you wanted to ask in 40 minutes, and appreciating such a limited time, we were not able to discuss chemotherapy and targeted agents in detail. I'm also really grateful for everybody's attention and those comments. If you could keep those comments going, it's really about generating a discussion, which I can see we're doing. I'm really grateful to everybody. So my job is not to talk too much. I'm just going to see how we are. We're actually quite good for time. We've got about 15 minutes, but I just thought we've had some really nice comments actually, both on the chat. Lots of thanks, and just want to thank everyone for their attention. Just going to see firstly if anybody has any questions that they wanted to ask. Otherwise, I can summarize some of the questions I've got from the chat and from things. But I'm just going to see if anybody wants to either put a question in the chat. I'm happy to pass that on, or in the actual WhatsApp group, or just raise a hand or speak. No need to be shy. We're all friends here today. Okay, well, let me start off actually. I know that there were some comments. Raza, you started off really, you started off, and the first thing you were talking actually about, which kind of struck me, which is always can be a little bit of a tricky issue, is this concept of referrals and high volume centers. What would you say? Oh, actually, I think, sorry, Ahmed, is that a question or is that a thumbs up? I think it's a thumbs up. Okay, my apologies. So, Raza, let's set the scene. You're back in Karachi now. What do you think would be the ideal model? What would be the message that you would want to kind of propagate or disseminate? Simple fixes for improving outcomes in soft tissue sarcomas. And then from the surgical side, and then Yolanda, I'd like you to answer the question from a radiotherapy and systemic perspective as well, please.
Thank you very much. It's a very important concept. We know that from published evidence that when sarcomas are managed at expert centers within a referral network in countries with a well-established health system, the outcomes are really significantly better compared to when they're not. How can we implement that model within healthcare systems with limited resources is the key question. And I would probably go back to maybe 5-6 years ago where I started, and that's the model that I followed. And so there are many things that we have discussed. One is having an understanding of the rarity and heterogeneity of the disease, and the fact that each of these different types of sarcomas are managed differently. So developing an understanding yourself, developing an interest yourself, and it starts by declaring that interest within your peers and starting discussing cases within them. The next step is actually trying to reduce the rates of inadvertent excisions by your hand. So the patients that we or myself are managing, I make sure that the extent of or the percentage of inadvertent excisions is as low as possible. And the next step is developing or getting expert opinion or advice regarding management of sarcomas. And therein comes the value of networking and collaboration. I was very fortunate to be able to network with the team or the sarcoma team at the National Cancer Institute in Milan, Dr. Alessandro Bronchi and Dr. Marco Fiore being two lead people there. And I would kind of contact them regarding every soft tissue sarcoma case that I would encounter. And in a matter of minutes, I'm not kidding, in a matter of minutes, within reasonable working hours, I would get a response and an expert advice on how to manage and work up these problems. And that really helped me understand and develop a kind of a grasp around how these problems are managed. And then the next step was enrolling in an international training program, which is run by ESSO and the European School of Soft Tissue Sarcoma Surgery, and visiting expert sarcoma centers. I think on top of that, then a collaboration within your local peers from different disciplines, radiation, pathology, radiology, medical oncology, and then discussing each case together and learning from each case with reflection, recording outcomes, publishing them, and learning from them. I think this is just a model that almost everyone would follow. Yolanda, over to you.
Thank you, Raz. Over to Yolanda. And just to let you know, Yolanda, we've got a couple of questions that have come through, which I'm going to put to our expert panel as well.
Yeah, no, sure. No, thank you so much, Raza and Shani, and completely agree. I think ultimately, from my perspective, in terms of how we can actually help to improve the radiotherapy pathways for patients with sarcoma, it is actually really important to try to develop a local radiotherapy protocol, which again is something that can actually guide not just clinicians in terms of voluming, but also physicists and treatment radiographers in terms of how we set up the patients, how we quality control the whole pathway of radiotherapy for the patient. Also, I think localizing patient information sheets into local languages and also local consent forms specifically tailored for sarcoma. One thing I've come across quite a bit as part of my global oncology training and capacity building is that often, units are really struggling to actually explain the potential side effects to patients and also to actually accurately document what the potential side effects are in terms of informed consent. So I think that is actually quite a low-hanging fruit, or an important sort of first step in trying to ensure that we improve the service that we deliver to patients in terms of information and consent. Also creating multidisciplinary meetings. I'm sure that many centers globally are already doing that on a weekly basis, but also moving to the next step of having radiotherapy audit meetings, which is something that we do on a weekly basis at the Marsden, where you actually bring in the entire team. So I think I mentioned about how important the other allied healthcare professionals are in our management of these patients, because it's easy enough to volume a patient, but actually what happens after that in terms of the planning process for radiotherapy, the treatment delivery, and of course managing the patients in terms of side effects. So when I first started sarcoma training, I obviously was quite afraid as well about the potential side effects, because I was treating patients in terms of volumes that were much larger, and much more bizarre than many of the other tumor sites that I had conventionally trained in. But actually I found that if you give patients good support with weekly clinical reviews, you ensure that you're proactively managing any potential side effects, and you're really including your nursing team and your radiographer treatment team in part of that process, the majority of patients can actually get through their treatments very effectively with minimal effects on quality of life. So for me, that's actually a really important consideration in terms of capacity building and improving our service. Yes, I completely agree with Raza as well. Sometimes it can be very challenging to try and actually run clinical trials in this area, but I think we can set up local regional databases that become registration studies, where we basically actually are able to record systematically the clinical outcomes of patients and in correlation to the treatments that they've had. And I think this is something we should actually consider doing more at a national level and also a regional networking level for many of our sarcoma units globally.
Thank you, Linda. So I'm aware of time. I think somebody from our admin team had a question, and I'm going to ask Professor Mugia Hussain as well. Firstly, from our admin team, sorry, you've got your hand up. Sorry, I couldn't see what the question was that you had.
I think it was, what is the overall incidence of sarcoma in head and neck, particularly in South Asian populations?
Yes.
Is that from Professor Zaidi? Sorry.
That's Dr. Shafi Zaidi. Yolanda, you're absolutely right. This one question. More than that, I think I've learned so much just now in this last 45 minutes. There was a time I used to do a lot of head and neck surgery in Pakistan. Mushir is here, he'll probably witness me and bear me out. And in Pakistan, oral cancer is a top killer. And once I remember, I did one case with a maxillofacial tumor. We didn't know what it was. It was diagnosed as sarcoma. In those days, of course, sarcoma was a very, very rare. I don't know what's happening now. So Dr. Manzoor Zaidi was a top radiotherapist. He, myself, and Professor Rab got involved to that case. And I did extensive, very, very extensive surgery in removing the orbit, the maxilla, the mandible, the neck dissection, and what have you. And I was ridiculed by everybody. Why did I do it? All it was needed was radiotherapy and chemotherapy. I was so puzzled that I came to England, I think I was in 1985, 86, and I went to see somebody at Royal Marsden. I don't know who it was, and I discussed, and even they didn't know whether sarcoma should be treated surgically or a combination. So it's eliminating for me that you're talking about surgery, chemo, and radiation. Of course, Raza, you have a task there to establish, let the people know in Pakistan that sarcoma has some aspect of it. Surgical intervention is necessary. Professor Mulazim Bukhari is sitting here. He has a lot of experience in dealing with pathology. And Mushir is sitting here. He can also guide us, because Raza being there, and of course Yolanda to go back to Malaysia, we can establish a network, and the SIVU will be at your service to coordinate these further activities. Thank you.
Thank you, Professor Zaidi. That's very, very eloquently put. Professor Hussain, Mushir Hussain, please, over to you next.
Thank you so much. I mean, I really enjoyed this. This was very useful for me. I've learned, as Professor Zaidi said, a lot in these 45 an hour nearly. But my question really is, within the UK, how many centres do we have of dedicated sarcoma centres that have this multimodality treatment and the rest of it that you've described, given that it's very rare?
I can answer that actually. So, I mean, with respect to both bone and soft tissue sarcoma centres in the UK, we have 19/21 centres, depending on how we define them. the issue here is that they are obviously geographically located to try and serve the population. Having said that, patients do unfortunately have to travel a variable distance. Some patients may only have to travel a few miles, other patients may have to travel 50 to 100 miles, even more. So that is an issue. The key here is that it's multimodality treatment, as you said, it's working together. So we've got, the definitive management for most of these sarcomas. As a non-surgeon, I will say it is actually usually surgery, I would say. These tumors really need to be healed with steel. Cold steel, sorry, Raza, I apologize. And then in the adjuvant setting, in the additional setting, there is a role for radiotherapy, as Yolanda eloquently put it. And then for some of our patients, there is a role for chemotherapy. The surgery really has to, I would say, you want a high volume center with specialist surgeons who are on very high volume kind of learning curve. The radiotherapy, once again, we should be giving in a center that is treating complex cases. But having said that, we do also outsource our radiotherapy to some of our local centers, and we peer review those volumes, as Yolanda was highlighting. And in the systemic therapy as well, the simple regimens, I say simple, the regimens that are given commonly for other tumor types, the drugs that are given for example, breast cancer, let's say, or usually breast cancer, let's say, or bladder cancers can be given by people locally, but anything requiring kind of more regular follow-up but side effects and more complex drug treatments would probably need to be given centrally. So you're absolutely right. We are kind of limited geographically because in the UK there are only about 5,000-6,000 cases diagnosed a year, and what you don't want to do is have 50 centers treating a handful. You'd rather have centralized services, and that's what the data suggests. I'm going to stop talking. I'm going to pass you back onto the panel, see if I want to add anything else, and I'm just mindful of time.
Just to add that there are more than the number of multidisciplinary teams that provide decision making for sarcoma are actually larger than the number of centers providing surgical care. So the surgical expertise is more centralized than the sarcoma MDTs. So if the patients that require surgical input, they are sent over to those centers.
Can I talk
for
a minute?
Sorry.
Oh, thank you very much. I'm Professor Bukhari from Pakistan. Basically, I am histopathologist, and around about I have 40-year experience in working histopathology in Pakistan. No doubt, it is not my question, but is the comment, and I cannot add something because you have talked too much, and excellent you and Dr. Raza, and thank you very much. A very nice talk. But the thing is that in Pakistan, we have 3-4 hospitals like Shaukat Khan hospitals. And in King Edward Medical University, we have some areas where we treat the soft tissue sarcoma. The important thing and the thing in before diagnosis is, before making the treatment is to reaching one is the diagnosis. And the very important thing, the diagnosis. You cannot rely on the radiology MRI until and unless we rely on the biopsy and then going on the immunomarker. When I was medical student, only there was, okay, diagnosed a high-grade sarcoma. But now there are specialized immunomarkers and cytogenetics and molecular genetics to make the differential diagnosis of grade 1, grade 2, and grade 3. One thing said. Another thing is why we classify that in Pakistan and thing that there are no doubt you have to treat with the radiation, chemotherapy. A certain sarcomas need the targeted therapy. That is why when no doubt we are a developing country, but we have very good center in Pakistan like Shaukat Khan hospitals and other centers. And thank you very much, Professor Zaidi, talking about me. And thank you, Mashid, and thank you very much. Thank you so much.
Professor Bukhari, you made a very fantastic point, and I'm just wondering if Yolanda and Raza in the last minute or two you want to address that, because absolutely it's about getting, we've been using these some people argue we've been using outdated techniques, which are very, very simple classifications for what clearly are very complex tumors. Basically, we can have two identically looking tumors in a pathology sample and they behave completely differently. What are we going to do about that? Yolanda and Raza, please.
I think the most important thing is having record of our outcomes and these discussions that take place on a regular basis based on which tumors progress and which stay better. We also need to incorporate translational disease, which is a model for improvement in understanding of rare diseases, that once we have a hindsight of which patients do better, we can actually look at how these tumors are different in terms of the current diagnostic modalities. So it's important to biobank and it's important to collaborate so that in future we can have a better understanding about tumors from today. And that's how we have come to this understanding of sarcomas. Just to kind of add one comment from based on the question, the surgical biopsy, incisional biopsy is just historic. We should not propagate it. We should develop capacity within institutions. And this is the right message, that core biopsy is the diagnostic modality for obtaining histopathology.
Okay, thank you. My objective was that we are doing here two types of the biopsy. One is the core biopsy, that the core biopsy we do before the diagnosis, and the surgical biopsy, no doubt the surgical, but then it is important. We are relying on the core biopsy. We are also applying the immunochemistry and the molecular genetics, because the treatment not only in the soft tissue sarcoma, but in every tumor, every cancer, depending which genetics is there, the mutation or overexpression. So surgical biopsy is only advised when it is inadequate or when it is required. Well, otherwise, the core biopsy is sufficient to make the diagnosis, immunomarker, cytogenetics, and the molecular genetics.
Thank you, sir.
Thank you for that discussion. You're absolutely right. There are some cases where you have difficult biopsies. And actually what we tend to do, I'm going to speak on behalf of Raz and our surgical team, is that we tend to do a repeat core biopsy. Absolutely. I'm just aware of time, and Anam Zaidis kindly asked a question once about SBRT. I think that's probably why you're raising your hand. Yolanda, would you be happy to address the role of SBRT in the next minute or so? Because I think we're just overrunning by a few minutes, but it's such a dynamic discussion. I really feel we can address this last one or two questions. Anna, was that your question, just to confirm?
Yeah. So I think
I'm going to take that as yes.
So I think currently the role of a stereotactic body radiotherapy, which is also known as CyberKnife, or that's a way of basically delivering stereotactic body radiotherapy, which is higher doses of radiotherapy per fraction, with the aim of basically trying to ablate the tumor. So it's a very interesting area of research, but at the moment, the indication for stereotactic body radiotherapy or CyberKnife treatment in sarcoma would really be in the oligometastatic setting, where we select patients carefully. We ensure that we think they probably have a longer term survival of at least more than 6 months and a good performance status before we basically refer them to our CyberKnife review board to make a decision about whether to proceed with CyberKnife treatment. And I think I showed you one of the pictures earlier on of a patient with metastatic leiomyosarcoma who basically had limited metastases, only metastases in the spinal trunk area. But because of the critical position and the fact that the tumor may actually impinge the canal and lead to spinal cord compression, they were recommended to receive stereotactic body radiotherapy using a CyberKnife technique. So I think it's definitely an area that needs more research and development. But I'd also like us to encourage to think about, what are actually the solutions as well, for low and middle income countries and for global oncology in terms of developing the radiotherapy service. And for me, I think one area that's very interesting, and I've been in discussions with Shani and also with Aisha Mia, another consultant at the Marsden, about how we could develop protocols for hypofractionated radiotherapy in sarcoma. So that means basically giving higher doses, but in less sessions, because we know in many areas of the world, it is a very, very big commitment and very difficult for patients to complete their treatment if they've actually got to come on a daily basis for 5 to 6 weeks or 6.5 weeks, even in the postoperative setting. So again, this is an area of research, but I think that's, we've seen in other tumor types with breast cancer, for example, or prostate cancer, that we can actually reduce the treatment time by giving higher fractions of radiotherapy. So we need to find a way of advancing research in sarcoma to see if we can actually do this safely in sarcoma as well, and thereby actually improve patient compliance and hopefully patient outcomes. So I think I'll stop there, but I hope that also helps to give a flavor of the direction of radiotherapy for sarcoma.
Thank you very much. I think we've run out of time. We've overrun a few minutes. I think it's been a really excellent session. I'm just so grateful that everybody has been so interactive, and we've had lots of good discussions and questions. And I think what we'll try and do is take some of these offline in the group chat, and if any haven't been answered, we'll leave our email addresses. We'll try obviously and do a follow on. But thank you once again to the admin team and to SIVU for inviting us. Thank you to our excellent speakers, making my job really, really easy today. And thank you everybody for engaging with us. And let's see if we can improve outcomes for patients internationally and do interesting things. The most important thing really is just to say that although these are rare tumors, and they have historically had less funding and poor outcomes, we can make a big difference just by firstly talking to each other, referring cases to each other and learning from each other. We're here to learn from you. International centers are here to learn from smaller centers, because I'm still learning, and I've only been doing sarcoma for about 8 years, as what I say. The day I stop learning is the day I need to retire. So thank you again, everybody, and my salams and best wishes to everybody, and I hope you all have a great weekend. Thank you.
Thank you. Bye-bye.
Thank you very much. Thank you. Bye.
And we'll be available on the group chat, or we'll be actually available on the WhatsApp group just to answer questions at any time.
Thank you so much. Very nice.
Thank you, Professor Bukhari. No, thank you very much. And I'm very aware we had some very senior members who were unable to join us, and I'm really, really looking forward to learn from their experience, actually, because whilst we talk about giving our experience in the UK and internationally, actually, we need to learn from everybody else internationally, what their local experience is and how we can help, and what we can learn from you as well, because that's how it works. Thank you again, everybody.